welcome to The Code Tray, the podcast of the ACCP Emergency Medicine PRN. I'm your host, Christian Kroll, an emergency medicine and ICU pharmacist at the University of Iowa Hospital and Clinics. To view this recorded presentation, head to our YouTube channel at youtube.com/@ACCP-EMED-PRN. And for PRN members, slides can be found under the Libraries and Trees section of the ACCP Communities website.
All right, everyone. So now for our second presenter, we have Zach Dougherty, who is a PGY2 EM resident at UofL Health. He will be presenting a journal club on cumulative epinephrine dose during cardiac arrest and neurological outcome after extracorporeal cardiopulmonary resuscitation.
I have no relevant financial disclosures to this presentation, and the objectives that we're going to be going over are discussing the roles of epinephrine in CPR, as well as the impact of epinephrine in favorable neurologic outcomes. We're going to describe extracorporeal cardiopulmonary resuscitation. It's going to be abbreviated ECPR during the majority of this presentation, and then analyzing recent literature regarding epinephrine in ECPR. So going into a little bit of background specifically on cardiac arrest. Cardiac arrest is the cessation of cardiac mechanical activity, and this is most often evidenced by the loss of a pulse, whether that's our peripheral pulses or a fem pulse. Some data here in 2021, there were a little over 180,000 cardiac arrests that were triaged and treated by EMS in the United States. That comes out to about 92 individuals per 100,000 people per year. On the in-hospital side, there were over 45,000 in-hospital cardiac arrests in 2021 as well. Looking at some survival data in cardiac arrest. So out-of-hospital cardiac arrest have about a 9.1% survival to hospital discharge. And this data still comes from that same 2021 data set. 7.1% of those out-of-hospital arrests are with good functional outcomes. In-hospital arrests have a higher cardiac arrest survival at 18.8%. And then if we think of some of the factors that impact survival, especially after a code situation, initial rhythm is a big one. So shockable rhythm does have a higher rate of survival at 25.9% compared to non-shockable at 5.7%. And then another really important factor is bystander CPR and early initiation of high quality compressions and ACLS and starting ACLS. Witnessed arrests have a 13.3% survival to hospital discharge, compared to an unwitnessed arrest, which is lower at 4.2%. This is just a snapshot of our current ACLS algorithm. And what I just want to point out on this is regardless of what side of the algorithm you're on, epinephrine is going to be our primary medication that we're using as we run through this. So regardless if you are in asystole and PEA, you're giving this epinephrine immediately, versus in your VFib, VTAC shockable arrests, you're going to be giving epinephrine after some failed defibrillation attempts. So going into a little bit about epinephrine specifically, like I mentioned, it's the primary medication used in our ACLS algorithm. It's an alpha and beta adrenergic agonist. The theoretical benefit of epinephrine is that it constricts the arterioles, raises overall blood pressure. This increases coronary blood flow and then increases the chance of return of spontaneous circulation, or ROSC. The current recommended dose of epinephrine in cardiac arrest is 1 milligram every 3 to 5 minutes for our algorithm. One piece of background literature that I did want to highlight regarding epinephrine in cardiac arrest is this published paper by Perkins and colleagues in 2018. It was a randomized double-blind trial of out-of-hospital cardiac arrest patients in the United Kingdom. And they specifically looked at epinephrine versus placebo in addition to standard ACLS care. And they looked at the rate of survival at 30 days. They included right around 4,000 patients in each group. And they found that the rate of survival in the epinephrine group was statistically higher, 3.2% versus 2.4% in the placebo group. However, looking at some secondary outcomes at the time of discharge for survivors, there was a higher rate of severe neurologic impairment in the epinephrine group versus the placebo group. So 31.0% had severe neurologic impairment in the epinephrine group versus 17.8% in the placebo group. So overall, the authors of this study concluded that yes, epinephrine does have statistically significant survival compared to placebo. There is no difference in favorable neurologic outcomes for epinephrine versus placebo. This is just a diagram that came out of that study. So they used the modified Rankin scale to assess neurologic outcomes, 0 being no disability and 6 being death. So for here, you can see that epinephrine group did have less death compared to placebo. There's poor neurologic outcomes, so a modified Rankin scale of 3, 4, or 5 did have higher rates of that in the placebo group, which is why they were unable to say that there is benefit or higher rate of favorable neurologic outcomes. The theory of why epinephrine has this poor outcome is that it initially improves that circulation through coronary artery perfusion, but repeated doses does constrict the blood vessels, especially in the brain, risking poor oxygenation and ischemia. Switching gears quickly to eCPR. So eCPR is an extension of conventional CPR where ROSC is not achieved using our standard ACLS protocols. It involves using ECMO cannulation to restore circulation. Typically, a VA ECMO circuit's used, so where that circuit is both the pump and the oxygenator for our body. And the goal of eCPR in general is just to reduce the low flow time during cardiac arrests, which is when we're giving chest compressions. Normal chest compressions only provide 15 to 25% of our normal cardiac output. And so using an ECMO circuit instead can theoretically provide 100% of your circulatory needs instead. And the goal is to continue this adequate circulation until a reversible cause of cardiac arrest is identified and treated. These are just some cool pictures that I wanted to share. So our pictures of mobile ECMO units. The one on the top left is actually from France. This is a picture of active ECMO cannulation in the Louvre in Paris. And then the other two pictures are from the University of Minnesota, their mobile ECMO unit. So this is kind of where eCPR is going. This is not very popular or widespread in the United States, but it is gaining traction with some systems who have the resources and the capability of doing that. Going into a little bit of the data surrounding eCPR, there's really 3 randomized controlled trials so far that I've looked at this. The first one being the ARREST trial, which was published in 2020. They looked at 30 patients in the United States with out-of-hospital cardiac arrest and specifically VFib initial rhythm. They looked at survival to hospital discharge, and they found that 43% of patients that were in the eCPR group had survival to hospital discharge compared to 7% in the conventional CPR group. I was eventually stopped early just because of the probability of ECMO superiority. The other trial, the hyperinvasive trial in 2022, also looked at out-of-hospital cardiac arrests in the Czech Republic. Specifically, they looked at 180-day survival with favorable neurologic outcomes, and they used a score called the Cerebral Performance Category score, which we'll talk about a little bit later. Favorable neurologic outcomes are defined as a score of 1 to 2. This study found that 31.5% of patients in the eCPR group had favorable neurologic outcomes versus 22% in conventional CPR, which was not statistically significant. This study was eventually stopped early as well. In this case, it was due to futility. Of note, with the hyperinvasive trial, they did look at favorable neurologic outcomes at 30 days, which was statistically significant, about 30% in the eCPR group versus about 18% in conventional CPR. And then one additional trial was recently published in 2023 by Suverin and colleagues, was a trial of 134 patients in the Netherlands with out-of-hospital cardiac arrest. They looked at 30-day survival with favorable neurologic outcomes, also using the CPC score, found that 20% of patients in that eCPR group had favorable neurologic outcomes compared to 16% in conventional CPR, which was not statistically significant. So overall, the data with the efficacy of eCPR is very mixed. Prior to these 3 randomized controlled trials, all the data was retrospective and very low-powered observational trials. Still, currently, the amount of data that we have for supporting eCPR is very limited. If we look at what the AHA currently recommends in regards to eCPR, they do put a very broad, not recommendation on it, but say it might be reasonable in select patients where standard ACLS care isn't effective and that patient is refractory to normal efforts to get ROSC. One potential caveat that they put on here is that it's reasonable in patients that have access to providers that have adequately trained facilities and equipment, just because ECMO in general, especially eCPR, it does have a very large resource burden and cost associated with it, which is one big reason why it's not more widely utilized. And so really the cost-benefit analysis of doing this is not well established or studied. And then they just recognize that further data as far as patient selection, inclusion criteria, outcomes and then notably complications with ECMO, because ECMO itself has its own risks. This needs to be collected and analyzed before there's a stronger recommendation. Currently, there's no standard recommended ECPR protocol or recommendations, and so the study that we're going to be talking about today puts an effort to try to add to that literature to try to help make better decisions when we're implementing ECPR. So that moves us on to our study, so cumulative epinephrine dosing by Garcia and colleagues. This study was recently published in the American Journal of Emergency Medicine in June of 2024. The authors of this study were based out of the Mayo Clinic Health System out in Rochester, Minnesota. They didn't disclose any potential financial conflicts. They recognize that there is no recommendations for epinephrine once you establish ECPR. And there's really questions that exist whether there might be additional harm that you're providing that circulation with an ECMO circuit, as we've seen with previous studies with epinephrine. And so that was the motivation of performing this study for them. The overall purpose to evaluate the impact of cumulative epinephrine dosing during cardiac arrest and then assessing neurologic outcome after ECPR. The study design for this paper, it was a retrospective single-center cohort study. This center does have access to an ECPR consult service that evaluates contraindications and indications for ECMO cannulation in patients with cardiac arrest. I put some of the absolute and relative contraindications for this consult service just so you get a better idea of what the patient population looks like at the center that undergoes ECPR. Some of the notable absolute contraindications were an unwitnessed arrest, initial asystole rhythm, no flow time. So that's time off of the chest, not doing compressions that are greater than 5 minutes. Low flow time, so doing conventional CPR for greater than 60 minutes. More evidence or knowledge of end-stage renal or liver disease. And then you can see some of the relative contraindications there on the right. More specific inclusion and exclusion criteria for the study. So they included adult patients with non-traumatic, both out-of-hospital and in-hospital cardiac arrests, then had successful resuscitation with ECMO, which was defined as achieving proper cannulation and getting proper flows during cardiac arrest. Exclusion criteria were unsuccessful ECMO initiation and ECMO indications other than ECPR. And in addition to ECMO cannulation, standard ACLS was utilized until the decision was made to cannulate for the patients included in the study. The outcomes that they looked at, so the primary outcome was the rate of favorable neurologic outcome at the time of hospital discharge. And they used the cerebral performance category as well as the other studies that we looked at did, defining that as a score of 1 to 2. So the CPC score is a 5-point scale that ranges from 1 being conscious alert with normal function or very slight disability up to a score of 4 or 5, which is comatose at 4 and then brain death at 5. So that's the scale being used in these studies to assess neurologic outcome. Secondary outcomes specifically looked at rates of adverse events. I'll go through all of these, but notably they looked at things like seizure activity, acute renal failure, shock liver, pulmonary edema, and death, among others. As far as the statistical plan, so for included patients, they split them up into a low-dose and a high-dose epinephrine group, where patients in the low-dose group received less than or equal to 3 milligrams of epinephrine during their CPR. And then the high-dose group, being those who received greater than 3 milligrams. T-tests and Wilcoxon breakdown tests were used on continuous data, and chi-squared and Fisher exact tests for categorical data. And then for the primary outcome, they used a multivariate logistic regression model to attempt to adjust for confounders. So going into specific results, so they analyzed 461 ECMO runs during the trial during the study period and ended up including 51 ECPR cases. 18 of those in the low-dose group and 33 of those were in the high-dose group. Baseline characteristics, you can see a selection here. So the median age in the low-dose group was about 66 years, 58 for the high-dose group. About 67% in the low-dose group were male compared to 48% in the high-dose group. And the majority of included patients were Caucasian. And these baseline characteristics were not statistically significant. There was a higher rate of smoking and alcoholism in the low epinephrine dose group, which were statistically different. And then you can see some of the rates of the initial rhythm there. This was not statistically different between the high dose and low dose groups, But you can see the most common initial rhythms that patients were cannulated on were PEA, ventricular fibrillation, or VFib. And then other notable differences, so CPR duration is also different, which makes sense if you're comparing a low-dose epinephrine versus a high-dose epinephrine group. Those patients that are going to be getting CPR for longer, if you're following the ACLS algorithm, are going to get more doses of epinephrine. But that median duration was 32 minutes in the low-dose group and 49 minutes in the high-dose group. And then you can see the median number of epinephrines, or the median milligrams administered. So 2 was the medium in the low-dose group, and then 8 epinephrines administered in the high-dose group, which was statistically significant. One additional thing that I want to point out is that 78% of the total arrests included were in-hospital cardiac arrests. They did include both in-hospital and out-of-hospital arrests. So that's just something to keep in mind as we're evaluating the results of this for patients with out-of-hospital cardiac arrest, which mostly present to the emergency department. The presumed cause of cardiac arrest, you can see the breakdown there. The vast majority were suspected myocardial infarction, 39% with the low-dose group and 27% in the high-dose group. Other notable presumed causes, PE, 15% in the high-dose group, and then cardiac tamponade also had a relatively significant showing there in both the low-dose and the high-dose group. One other thing that they point out was the location of ECMO cannulation. So because they included both in-hospital and out-of-hospital cardiac arrests, the actual location that they did ECMO cannulation was varied. The most common time or place was the cardiac cath lab at 24%, followed by the operating room. And then 18% of the cases included in this study were actually cannulated in the emergency department. So again, something that is still relevant in the emergency department for a pharmacist to be aware that ECMO cannulation can be there if the resources are available. So the primary outcome, and looking at the data specifically, again, looking at favorable neurologic outcomes at 30 days, was statistically significant, with 56% in the low-dose group having favorable neurologic outcomes versus 24% in the high-dose group. Adjusting for age using that logistic regression model also found a statistically significant difference favoring the low-dose group, with an odds ratio of 4.6 favoring the low-dose group having higher favorable neurologic outcomes. For secondary outcomes, you can see the breakdown of adverse events here. All of these rates of adverse events were not statistically significant except for death. There was a significantly higher rate of death in our high-dose group at 73% compared to 39% in our low-dose group, with a p-value of 0.018. Of the patients that survived, 85% of those patients were eventually discharged home. Some other things I want to point out, although not statistically significant, you can see that there are higher rates of acute renal failure, cerebral edema, pulmonary edema, shock liver in that high-dose epinephrine group, which makes sense based on the mechanism of epinephrine and the risk for vasoconstriction impacting some of our end organs. So the author's overall conclusion that adjusting for age, cumulative epinephrine doses greater than 3 milligrams are associated with unfavorable neurologic outcomes. And they said it might be reasonable to limit epinephrine doses to 3 milligrams in those eCPR candidates. So then, reviewing this paper, some strengths and limitations that I pulled out. So strengths, the primary outcome is appropriate. They used the CPC score, which is the score being used in our other eCPR trials that we looked at, and that was statistically significant. And the results are consistent with prior data regarding epinephrine and favorable neurologic outcomes. Some limitations, a retrospective design with a low sample size, and so the results are really only hypothesis generating. It's really hard to make a strong recommendation based off the results of these studies, but does lead into the thought that we can maybe do larger trials to look at this even more. A CPR duration, as we talked about earlier, was statistically different between the groups, but not controlled in the regression model. Again, this is really hard because you're going to have longer CPR if you're going to get, or you're going to get more epinephrine if you have longer CPR. But just the fact that you are having a longer time down without ROSC does put you at higher risk for poor outcomes. And then finally, including both out-of-hospital and in-hospital cardiac arrests, it does just make the generalizability pretty difficult. We're trying to apply this to out-of-hospital cardiac arrests specifically because the rate of in-hospital arrests were so high in this trial. So overall conclusions for me, looking at this trial, results are consistent with kind of our current concerns with epinephrine and neurologic outcomes with conventional CPR. Overall, it just makes sense and puts more weight into those conversations about the benefit of continually escalating doses of epinephrine in longer arrests. And then for institutions that do have eCPR teams and capabilities with readily available access to different interventions that can include PCI, thrombectomy, thrombolytics, it can be reasonable to discuss the risk and benefit of escalating epinephrine doses, and that conversation can be reasonable in some of these circumstances. And then just overall, the general need to have larger randomized controlled trials eCPR. Again, this modality isn't super widespread, super common. But as hospitals and emergency departments have more access, are getting more resources, and expanding what services they're able to offer, definitely the ability to do larger trials needs to really be thought about to really know where eCPR fits within our standard of care. I have some references here if you want to get those, and I'm happy to take any questions.
If you have enjoyed this presentation content and would like to hear more, subscribe via your favorite podcasting app. Additionally, make sure to check out our YouTube page for all recorded presentations. Thank you for listening to this week's ACCP Emergency Medicine Journal Club presentation. Join us weekly for review and discussion of new journal articles in emergency medicine. This podcast provides general information only and does not offer individualized medical or professional healthcare services, including pharmaceutical advice. The contents and materials in the podcast are not intended to be a substitute for inpatient pharmaceutical advice, diagnosis, or treatment. And the use of the contents and materials in the podcast does not constitute a pharmacist-patient relationship. As a result, the information in and materials linked to this podcast are applied at the user or patient's own risk. Users or patients should consult their physician or personal healthcare professional. The user or patient should not ignore or delay seeking care because of something they heard on this podcast. In case of an emergency, the user or patient should contact their physician, call 911, or go to the nearest medical emergency facility. The views and statements expressed on this podcast are those of the host and guest and should not be interpreted to reflect the official position or policy of ACCP or the Emergency Medicine PRN.